I'm happy to talk about the Vioxx that's in my cabinet at home. I also have trovafloxacin. I don't know if you remember that one, but it was a great fluoroquinolone that killed your liver, but it worked. So I have both of those at my house if you need them. I'm going to talk about vaccinations and give you an overview of how, well, I guess a couple things. One, what vaccines you should care about, and two, how to use them. And really make some comments around what the drugs you're using might do or not do to the vaccine responses and the immunogenicity of the vaccines themselves. And then hopefully give you some, some pertinent advice about how to handle some of your difficult patients. Here's your list of vaccines that I mocked up years ago just on the plane somewhere, and I just thought of, how do you think about these things? Well, I think about them, they're either live or they're not live. And if they're live, then of course you may have to worry about them. If they're not live, you don't have to worry about them. You can give them whenever you want, but the drugs you're using may not make the vaccines work as well, and that's what we'll focus on. On the live side, I just have in bold there the influenza nasal vaccine, which you don't really have to worry about because it's live. And most of your patients are immunosuppressed enough that they probably shouldn't be getting live vaccines. Now, that does not extend to prednisone and methotrexate at normal doses. That's really just with regards to biologics. People who are on low-dose prednisone or methotrexate at your usual doses can go ahead and receive these vaccines. And I'm going to talk really specifically about the shingles vaccine a bit later. Some of the other vaccines that are listed, these are travel vaccines that you probably don't need to worry about. You can send your patient to someone like me to deal with it, or they're in the military and they have smallpox vaccine, things like that. These are not things that you have to worry about, luckily. So I'll start with a case study. This was a real patient, Atul Deodar at OHSU had sent over to me a couple years ago, and she was a 52-year-old woman with RA. And it was October, so that's the big hint there. It was fall. She was on, I guess, somewhat maximal doses of methotrexate and prednisone, and I'll just make the comment that to me is a high dose of prednisone. I'd like to see that lower with regard to infectious risk. So she was kind of maxed out on her therapies, and he was considering a biologic. She was very savvy and educated. She was from Switzerland, and she really wanted to talk about lowering her risk of infection, and she was worried about that with her biologic. She'd had BCG as a kid, and I knew that because, like everyone from Switzerland, they carry their vaccine card in their wallet around with them for 50 years. It was kind of funny. She actually had that little yellow card with signatures by some high-ranking public health official in Geneva, indicating that she'd received XYZ at certain age points in her life. But she had BCG. Despite that, she'd had a positive skin test a long time ago. They just decided to treat her, and they gave her 6 months of isoniazid, so that was kind of off the table. She'd also, interestingly, had shingles, probably because her prednisone had been raised recently, and that was 6 months ago. She was now in the U.S. She's at higher risk for respiratory disease. She has COPD, and again, she had no vaccines really since childhood, and I could see that from her vaccine card. So here's where it got fun, and this is my usual vaccine interaction. I said, well, I think you should get the influenza vaccine because it's October. And she said, well, I have an egg allergy. And I said, really? What do you mean? I mean, don't you eat eggs? She said, yeah, I eat eggs, but they kind of, they make me sick. They give my stomach kind of a turn. I said, well, you don't have an allergy. She said, yeah, my naturopath said I have an allergy. I said, okay, well, the good news is you can still take the flu vaccine even if you're quote-unquote allergic. The only contraindication is if you have prior anaphylaxis. And I showed her the CDC guidance that said that, and I tried to reassure her. And then she said, well, I don't care because my husband gets the flu every time he gets the flu shot. So I said, all right, well, that's just happenstance. It's a killed vaccine, or, it's not live. It can't give you blah, blah, blah. Anyway, I gave her the spiel about that. Then she said, well, that's fine, but they have mercury in them, and I'm worried about getting Alzheimer's disease. And I said, actually, it's autism, and I'm thinking maybe you should get some. I didn't really say that, but that was what was in my head, and luckily I'm young enough, I still check thoughts like that. Anyway, we talked about the fears around Alzheimer's and autism, and I tried to reassure her that there was no data to support those fears. Despite that, she refused the influenza vaccine. So I'll tell you what vaccine I gave her later. So anyway, if you could convince her to take one vaccine, which I did, this would be your wish list here. What vaccine would you prioritize as most important for her today? And I guess you can just answer on your keypads, and then do I press this button after 10 seconds, I guess, or just automatic? Perfect. Yeah, that's good. So it's funny, when I gave this talk, like say a year ago, and I'd asked this question, Prevnar 13D wasn't even coming up. I mean, definitely in the last year or two, this has become the #1 pick among rheumatologists when I give this talk. And that is probably the right answer, although I kind of told you I was trying to push the flu vaccine on her because it was October. But given I failed, that is the next one probably to go to, and that is the one I convinced her to take, so excellent work. The nasal influenza vaccine, I already told you, is live. It's really not for her. It's not for your patients. So I think, you could make an argument for any of the other 4 choices up there, and I think you wouldn't go wrong with any of them. But I'll mention also shingles vaccine. I'll get into that a little bit later, but she had a recent shingles bout, so she essentially vaccinated herself. So I'm not sure she'd probably benefit that much from the shingles vaccine at this point. You might want to wait another year or 2 before giving it. But of course, she's pre-biologic, and you want to use it before she goes on biologic. So I can see the issue there of wanting to try to get it in. So how do your DMARDs affect the vaccines we're talking about? So we made this little table for a rheum journal recently, and we reviewed the literature. And you can see lots of question marks first, just to show you on the lower part of the screen. A lot of the vaccines we don't have information about, but the ones we do are pretty much the first 2 rows, influenza and pneumococcus. And you can see the downward arrows, particularly the double downward arrows for rituximab. So as you're probably aware, I mean, rituximab strongly downregulates humoral responses. I mean, you deplete your B cells. So any vaccine you're going to give in someone on rituximab, I would give it as long or as far away as possible from their last rituximab administration. So that's one point. The other point of this table, and I do have a pointer here, I guess, is influenza vaccine pretty much holds up well with all these drugs. There is a downward arrow with abatacept. That was one study done with the pandemic flu vaccine, the H1N1 vaccine a few years ago, and it wasn't a very strong vaccine. So I don't really know how ABA affects vaccine responses, but for right now, maybe there's some diminishment. As far as pneumococcus, they hold up well, and this is really Pneumovax. There's no studies with PCV13 yet, which I'll get to. But it's fine with TNF blockers. Really what you need to think about is the downregulation from methotrexate and TOFA. And this was a study we did, actually, and I'll just show you. You can just focus on serotype 1 there because the same trend is seen in all the serotypes. But this is the geometric fold mean response after vaccination. And there's 4 groups here. There's a group on the left that's placebo, and then there was a group that was really methotrexate, and then TOFA plus methotrexate. And you can see if you're methotrexate only or TOFA plus methotrexate, you really see a diminishment of the GMFR or the response to that vaccine. And again, you can see that with all the serotypes. And there even seems to be a little synergism with the 2 drugs when they're together, because we saw the lowest responses in that group. So if you can, try to use this vaccine when they haven't started these drugs yet or when they're not on them. What do we know about PCV13? So this is a protein conjugate vaccine as opposed to the polysaccharide Pneumovax. So the idea is that the protein conjugate vaccine should be more immunogenic. That's what we see in the vaccine world. I don't have my 6 or 8 slides here reviewing that issue around this vaccine because the studies haven't been done yet. There are studies with the old conjugate vaccine, PCV7, and PCV7 actually doesn't look any more immunogenic than Pneumovax when it's studied in immunocompromised settings. There is 1 or 2 studies from the rheumatology setting. There's studies from transplant, from HIV, and it doesn't look more immunogenic. The thing we don't know is just because some vaccine boosts your immunity higher or lower, we don't know if that translates into differential effectiveness, and those type of studies have to be have to be done still. So with PCV13, there still is this hope that maybe it's more immunogenic, maybe it's more effective, but I really don't know until I've seen that data and seen those studies. What I have seen is just the pivotal trial, and there's a few other studies, but this was a pivotal trial of PCV13 in the Netherlands. And the nice thing about the study were the following. Number one, the Netherlands is interesting. The Dutch don't use Pneumovax. They're essentially a Pneumovax naive population. They don't believe in it. They don't think it works very well. So this was a nice place to take PCV13 and do a randomized controlled trial. So they randomized people to this vaccine or placebo, and they actually showed the vaccine was protective against pneumonia, 45% efficacy, and also protective against invasive pneumococcal disease. This was really interesting because for Pneumovax, it's been controversial for years how much Pneumovax actually protects you against pneumonia. There's been dozens and dozens of studies on the topic, and many of the studies have found very little effect at all. So this was, I think, an impressive result, at least with this level of efficacy. So how do you use PCV13, and how do you use it in the context of Pneumovax? So these are your categories of people. So if you have no history of pneumococcal vaccine, then it's easy. You give them PCV13, and then 8 or 12 weeks later, up to a year later, you give them Pneumovax. So you're using a protein conjugate vaccine essentially to boost a subsequent polysaccharide vaccine response. This is an old strategy we've used in the vaccine world for decades, really. So again, you have no history, you get PCV13, a few months later, you get Pneumovax. What about if you've had a prior Pneumovax? And a lot of your patients are in that bucket. If you've had a prior Pneumovax, then you look to see when it was, and if it's been at least a year, you give them the PCV13. And then you give them a Pneumovax booster 5 years after the first one. So you kind of keep them on their Q5-year schedule. If they've had 2 Pneumovaxes before, I call this the grandma bucket. The reason why is because Matt Moore, my good friend at CDC who wrote these recommendations, before they came out, I think I was struggling with this bucket. Someone asked me the question, hey, I got someone who's gotten 2 Pneumovaxes before, what do I do with them? So I said, I don't know, I'll call Matt Moore. So I called Matt Moore and I said, hey, what would you do with this lady who's got 2 Pneumovaxes? She's like, well, it's kind of like my grandma. He said, I would just give my grandma the PCV13. That's what I would do. I was like, there's no data, right? He's like, no, there's no data, but that's what I do. Well, then 2 weeks later, these recommendations came out. So I thought, oh, that's funny. I think this is the grandma bucket. But so he did what he would do for his grandma, which is actually not a bad way to practice if you think about it. Bottom line is, if you've had 2 Pneumovaxes, then just give them PCV13 and they're done. There is another issue with repeated Pneumovax administration. You can notice that you really only get 2 your whole life, and that's because there's studies that show that the more times you give it, there is this mutagenicity issue that actually your titers to Pneumovax decline. So back in the managed care days in Oregon, one of our metrics as hospitalists was, we had to give Pneumovax to everyone who came in the door. And there were people in Portland that probably ended up with 8 to 10 Pneumovaxes, in a couple years' time. And I'm sure we did them a disservice. That's my feeling. But I got paid more. Influenza vaccine. Let's see. Your choice here is between the high dose and the quadrivalent. And this is the last year you have to make this choice. The high dose is a trivalent vaccine, and it's meant for those over 65 years old, and I'll show you that data in a second. The quadrivalent is the usual seasonal vaccine, and here are the constituents this year. You notice they're all nice places with beaches. I think that's how they come up with this list every year. They added a Phuket B strain last year, and so really you get protection against all 4. If you use, again, the high dose, you only get the 3 in white. I already talked about the egg allergy being a non-issue. There's also a recombinant vaccine that if they do have a true egg allergy, if they really are anaphylactic to egg products, they can still receive a vaccine, and you'd use the recombinant vaccine. I don't know what I was going for here. I think I was going to Hawaii to give a talk, and I was trying to make everyone there feel better that they had low spread activity. But you can look every week and see what's going on around the country. And if you're in dark here, you're in widespread activity for flu. And we had pretty widespread activity this year. It's been a decent flu year kind of all the year round and everywhere. So all the more reason to give the vaccine. So I have another question here. So let's see. Oh, this is fun. This is where I really come clean and kind of admit that everything I'm telling you is a bunch of BS. Okay, the efficacy of last year's live intranasal influenza vaccine was, go ahead and choose. So this would be the 2015-16 intranasal. And I already told you don't have to use this vaccine, but this is just more for fun. Okay, so those of you in A are the winners. It was 0%. In fact, the estimate was negative something. It was negative like 0.1% with confidence intervals around 0. So actually this year, the CDC for the first time in my memory, or to my knowledge, they basically said don't use this vaccine, it doesn't work. And of course, I've been using this vaccine, my kids, every year, and wondering why they keep getting influenza every year. So now I know. What about the regular seasonal vaccine? So this is where I'm coming clean. So Ed Belongia is a good guy, and he does a lot of vaccine studies. He did some of these, not all of them, but you can see in the last 10 years, the adjusted overall vaccine effectiveness has ranged from 10% to 47%. It's not enough. It's not a very good vaccine. Even a couple years ago, it was 23%. And I don't know if you remember that year. That was the year that one of the vaccine manufacturers found out all their trucks in the Southeast were not refrigerated. So all the vaccine in September was sitting around these trucks, and it was 110 degrees in Georgia or wherever. And anyway, the vaccine didn't work very well afterwards. So anyway, weird things happen out there. So you have to just kind of go forward with optimism and hope. But I think there's an effort to make this better. And I guess that's my point of the slide is I want to, we need a better vaccine. And there are people working on this. And my hope is that eventually we'll have a better vaccine. Rumor is that this year it's doing better. And a lot of this has to do, of course, with mismatch or match with the strains in the vaccine and what's circulating. And I think right now we're in the 60 to 70% range last time I checked. So here's the data around the high-dose flu. If you're 65 and older, I use it. CDC has a soft recommendation around this. They say, yeah, you probably should use it, but they don't say you should. It's really just because there's one study, but there was 25 or 24% more efficacy with the high dose versus the standard dose. And again, this was people age 65 and up, and there was no difference in SAEs between the vaccines. So my practice is if you're 65 and up, I give you this vaccine, unless you're going to Phuket, and then I give you the quadrivalent because you get the extra B. I'm joking. But shingles vaccine. Let's talk about shingles. So Jeff Curtis and I have worked really closely on this issue, and this is age standardized and sex standardized data, so the incidence rates don't really mean anything. If you look at whatever the incidence is of zoster for a healthy individual, then you can just compare and look across the board at all your diseases. IBD is not your disease, but lupus, RA, PSA, AS. And you can see that everybody that you deal with has a higher risk of shingles than a similarly aged and sex-matched individual in the healthy population. So, I mean, look at lupus. I mean, you're talking about 3 and 3.5-fold increase. Another reason to prevent shingles, and this was a study Len did that I was fortunate to help with, and it was a great study because, we all know this data that, if you get it, it's not very fun, and you have 15% chance of having post-parhetic neuralgia. Most of us will get it in life, or at least 1/3 of us will get it in life. But there is this complication of maybe stroke. Certainly some people get this stuff in your eye, and you can go blind. It's a problem, particularly if you have repeated insults. But then we looked with Len, and we found that if you, in the first 90 days, this is your incidence rate of having a stroke if you have zoster, but your incidence rate's essentially doubled if you have zoster in the cranial nerve distribution, suggesting that that's the risk for stroke. And it's not just us that have found this. Several other papers have also found this. So it's just another reason to prevent zoster in my mind. What is the risk of zoster? We looked at this across all the biologics not too long ago, and we found that the risk is, between kind of one and 2 per 100 patient years for all the drugs. And when you adjust for risk factors, there's really no difference between any of the biologics. They all carry about the same risk. What's in red here is the dose-dependent risk increase with prednisone. And again, if you can limit the prednisone use of your patients, you're doing a benefit. There is something different about the JAK inhibitors, as you know. There is a viral signal with the JAKs, and certainly we've seen that very prominently with herpes zoster and tofacitinib, and now we're seeing it also with baricitinib. We reported previously the increased risk with tofa from the development program data. Jeff and I then went to the real-world data, and we also took a look, and we found exactly what we've seen with the development program. This is the risk with tofa right here. You can see it's about 2-fold higher than any of the biologics, and this was in a U.S. health plan data. And this is exactly what we thought. So what was the risk elevation there? I don't know, it was about 2-fold exactly. We also saw a risk increase with herpes simplex as well. Here's the baricitinib data. You see overall rates of zoster that kind of drop with time. These are buckets of exposure in months, and it should drop with time because you get depletion of the susceptibles and survivor bias, et cetera. But the overall rates kind of early on are around the 3.5 to 4 per 100 patient year range, which is similar to tofacitinib. And similar to tofacitinib also, there is this increased risk in Asian populations. And we really don't know why. This is in Japan. The highest risk in the berry program was seen there. Rates were 6.5 per 100 patient years compared to only 3.3 overall, so really double the risk in Japan. It's exactly what was seen with tofacitinib. How about prevention prior to JAK inhibition? This was a study I helped Pfizer with. It was really nicely done study. We wanted to see if we could prevent zoster, and we had about 55 people per arm. And what we did is we took people and we vaccinated them with Zostavax, and then 2 to 3 weeks later, they started either tofa or they started placebo. And then at week 6, we measured their vaccine titers. You can measure a IgG response, and you can also measure a T-cell specific response using an interferon gamma release assay. And the T-cell specific response is really the most important one, and you can just look here at 6 weeks that the responses in placebo and tofacitinib, this is baseline here. You can see they're higher now, these responses in both groups, and even a little higher for the tofa group. So both groups responded really where they should have. What was fascinating about this study, though, and really the take-home message is that one patient disseminated the vaccine. And this patient, actually, when we went back and looked, out of the 110 or 15 people in this study, it was the only person who had no history of chickenpox. And it turned out they had no primary immunity, so it doesn't surprise me then that they didn't necessarily handle the vaccine well. So they got vaccinated. 2 weeks later, they started tofa, and then they disseminated the vaccine about 2 days later. Now, they were treated with antivirals. They got better. They did fine, and they actually went back on tofa. But the bottom line is it raised a question, if you lack pre-existing immunity, you really shouldn't be getting this vaccine. And presently, the vaccine is labeled to just go ahead and give it to anybody over age 50 because pretty much everybody over age 50 in the U.S. has pre-existing immunity. However, not everybody has RA, and not everybody's going on a JAK inhibitor. So probably, prior to starting your immunosuppressive regimen, this actually changed my practice. I at least ask about a chickenpox history, and if they don't have one, I check a serology. Zostavax, this was a great study that we did just from sitting around the table. We thought, God, I wonder if people get Zostavax anyway, even though they're not supposed to. It's contraindicated if you're on TNF blockers or biologics. And in fact, we found 550 people in the Medicare database that had been inadvertently vaccinated, and none of them seemed to have adverse events. And in fact, when we looked at whether the vaccine was protective, we found it was about 50% protective. This is the incidence rate in unvaccinated versus vaccinated. It was about half in the vaccine group. So it led us to construct a trial called the Verve trial that Len helped get off the ground. And we are enrolling people actively on TNF blockers and giving them this live vaccine. And so far, we have about 200 people randomized. and we've had really no vaccine adverse events or no events of vaccine dissemination so far. So hopefully in a few months I'll be able to report those results and tell you that it's safe to do. But until then, it's contraindicated. So the last question, a booster vaccination for Zostavax is recommended at? Yeah, so you guys know it. So it's not recommended. I often get asked this question, but the 69% is correct. It's not recommended. See, it might be that it should be recommended. So this is data that we published. Others have also published similar data in the last year. And if you look at the incidence rate of zoster in people vaccinated, this is the red bar or orange bar, compared to unvaccinated, again, you see in the first year after vaccination, it's about half, so it's very protective. But once you get to about year 5, you see that these estimates start going closer, and you can see that the 95% confidence intervals start overlapping. So it's really about year 5 or 6, there's no statistical difference between vaccinated and unvaccinated patients. So it might be that that's the time we should be boosting them. And so that's something I think we need to study further and consider, but that's an issue. Lastly, I'll just remind you, ACR does recommend giving the vaccine in those age 50 and older. I talked about the contraindications, and it's okay to give with regular dose prednisone and methotrexate. The last word on this is just that, if you look at the incidence rate of patients in the healthy population in the age 60 to 70 group, which is the group where the ACIP has deemed this to be a cost-effective vaccine, if you try to see in your disease groups what incidence rates are similar or worse, such that you think that it would make sense to vaccinate, the red boxes tell you what age groups the incidence is much higher. So you can see for lupus, it's even more common in 20 to 30-year-olds than it is in a healthy 60 to 70-year-old. So the reason why we did this analysis was we felt that ACR should probably move their recommendation from greater than 60 to at least greater than 50 for patients with RA, and they actually did after this study and several others were published. But the bottom line is most of the patients in your disease groups have incidences that really would justify vaccinating at much lower rates. So I think that's or lower age groups. So that's something we need to examine more with study. Now, it might be a moot point because this is your vaccine coming that's killed, and it might be useful to you, but I'm not sure. This is the soapbox tree. It's my friend's house in San Francisco, and this is a tree from Chile. And this tree is there's some protein in this tree that's being used in the new vaccine, and it's highly, highly immunogenic. So it's a new killed subunit vaccine, and that immune adjuvant has led to really very high efficacy in 96%, no matter the age group. This was published in New England Journal last year. Now, these are healthy individuals. These aren't immunosuppressed individuals. They're not patients with rheumatic disease. There was a lot of reactogenicity with the vaccine, I think because of this adjuvant. So we need to study it in your folks. I'm not sure. I mean, it might cause a lupus flare. It might cause an RA flare, and also might not. And so we need to do a prospective study to figure out if it will be useful to you. Lastly, HBV prevalence. This is actually the map of TB prevalence, and I retitled it HBV prevalence because it's the same exact map. It's the same people coming from the same places, and I always like to make that point. HBV, this is a vaccine you can consider, but a lot of your patients, if they haven't had it, it's probably a reason. The reason is they don't have risk factors for it, so they probably don't need it. Really, it's just these people with all these acronyms, some of my favorites, IVDU, MSM, healthcare worker, MSM, men who have sex with men, IV drug users, et cetera. If they have these risk factors, give it. More recently, because of outbreaks among diabetics using glucometers, that has been added to the list if they're a diabetic who uses a glucometer. But otherwise, they probably don't need the vaccine. If you do give it to them, you can measure their titer afterwards to see if they've responded. It doesn't cause flares of disease. This has been well established with lupus studies. There is some data showing that TNF blockers decrease responses. There's one study in SPA that showed that, and actually a lot of that comes from the IBD literature where there's a number of studies showing that. It is a T-cell dependent vaccine, so it doesn't surprise me that TNF blockers might downregulate responses. You can double the dose, or you can give the vaccine series an extra time if you really, really need to produce immunity. Lastly, I'm kind of ending the same way that Elaine did, just that we don't do a very good job of vaccinating. This was a study, actually this isn't you guys, this is the UK, that I helped do this study where we looked in their general practice database, and just to show you, only 50% of patients with RA had been given pneumonia vaccine, and 79% flu vaccine. But if you looked on a yearly basis, only about half were getting it yearly like they should be. I can show you 10 studies like this in the US or wherever, doesn't matter where you are in the world. Patients don't get vaccinated as much as they should. And I think a lot of that has to do with who should be doing it. I think similar to what you were talking about with cardiovascular prevention and risk factors. Is it the primary care doctor's job? Is it the specialist's job? And how do you communicate between each other to make sure it gets done? And those are challenges I think that we will solve as we get better healthcare tools, et cetera. So in conclusion, best time to vaccinate: before methotrexate and tofa, or before biologics in general, but definitely before rituximab. If it's not possible, just don't worry about it, do it anyway. That's what I say. Research agenda, we need some data on PCV13. We don't have any. And then I think shingles prevention is still a moving target. I think we're making some headway with Zostavax, and we'll see about this new vaccine and see if it's useful. It's not approved yet. It'll probably be approved later this year, so we'll see.